Welcome everyone. It's a little cold outside, so I'm a little slow, but Dr. Kardon is a professor of neuro-ophthalmology and Pomeranz Family Endowed Chair in Ophthalmology at University of Iowa, and he's also the chief of Rehab Center for Excellence, which has focus on the vision and ophthalmology at Iowa VA. And he is one of our elite colleagues in neuro-ophthalmology and clinical visual neurosciences, and he also mentors one of our own who trained with us, Matt Turtle, who is now in Iowa. So I don't know how many people know Matt, but he used to be here when I was an intern. Welcome, Dr. Kardon.
Thank you for coming out on a cold afternoon. I wanted to present some things that I thought would be relevant to this group. You might think, how can the eye be relevant to spinal cord and neuroprosthesis and brain injury? But I'm going to show you how it can be. These are my financial disclosures, none of which will adversely influence what I'm going to say today. I've been involved in a number of different aspects, and these have related to functional imaging of the eye. For example, here we present visual stimulation onto the retina, and we can activate neurons that we can see with near-infrared light. It's kind of an interesting technique to visualize neural activation. We've used adaptive optics to look at retinal blood vessel changes in the wall during hypertension and treatment of hypertension. And we've used imaging a lot to image. You can even see the axons of nerves in the eye traversing along the retina, which feed into the optic nerve, and study their loss in different optic nerve disorders. We've looked at optical coherence tomography and how that changes the displacement of the retina when raised intracranial pressure occurs, which is transmitted to the optic nerve. We look at the pupillary light reflex as a means of objectively assessing visual function. We're now using the grimace response too as an objective measure of pain. And we also use retinal oximetry to look at changes of oxygen in the retina, and also OCT angiography, which is a way of looking at capillaries in the living retina without injecting dye. And we've been using adaptive optics recently to look at the spatial patterns of nerve loss in the retina in different conditions. But today I wanted to focus on retinal blood flow, and using a technique that you may or may not be familiar with called laser speckle flowography. And this allows you in the human and in animal models to give you the dynamics of blood flow during the cardiac cycle and different things that influence it. And I want to show you how what we're doing in the retina is also relevant to studying the same processes in the brain and the spinal cord during normal and during injury. So just to kind of orient you, because some of you may not be familiar with the eye circulation, the eye circulation has two main circulatory sources. The central retinal artery, which comes through the optic nerve and supplies the inner retina. And this is when you look in with an ophthalmoscope or when an eye doctor takes a picture, shown in the upper right here, you see branches of the central retinal artery and then the central retinal vein, which drains blood back from the retina. And this vascular supply supplies the inner retina, the layers of the retina towards the vitreous cavity. This is where the retinal ganglion cells are located and their axons, which eventually converge and make up the optic nerve. And then there's also a second circulation, which is supplied by the posterior ciliary arteries. That supplies the choroid, and that supplies blood flow to the outer retina where the photoreceptors, the rods and cones, are located. And this circulation also sends branches to the optic nerve head. So we've got the optic nerve circulation derived from the posterior ciliary arteries, and this mainly comes from the ophthalmic artery, from the carotid artery. And we've got the central retinal artery, which supplies the inner retina that also comes from the ophthalmic artery. And what's interesting about these circulations is that the retinal circulation mimics mainly the gray matter of the brain. And the optic nerve circulation of the optic nerve head behaves similar to the white matter circulation. And the choroidal circulation is very similar to the renal circulation in the periphery. And so these different circulations behave differently to autoregulation when blood pressure or perfusion pressure changes, when the autonomic nervous system is stimulated, and all these have relevance to the brain circulation and the spinal cord in terms of their behavior. This is just a close-up of the optic nerve head circulation, blowing this area up, supplied again by this posterior ciliary artery, which sends branches into the optic nerve head here. And that's very important circulation in different ischemic optic neuropathies where patients often wake up blind because their blood pressure dropped too low during sleep. So it has a lot of similarities to watershed zones in the brain and the spinal cord, which I'm going to cover briefly in a few minutes. Back 30 years ago, the way we had available to study the retinal circulation was injecting a fluorescent dye, which we still do nowadays, that shows the filling just like angiography does for the brain and spinal cord. But nowadays we have OCT angiography, which is a way of actually visualizing all the capillaries where blood is flowing through at the time that the imaging has taken place. So this relies on movement of red blood cells and extracts vessels where movement is occurring at the time of the imaging, which just takes two or 3 seconds to do. And you can see the resolution is incredible without injecting a dye. And back 50 years ago, I studied this with injecting methyl methacrylate modified to be the viscosity of blood, digesting the tissue in animal models and looking at the capillaries. Then we had the same thing, like I said, 30 years ago with fluorescein angiography in the same area now captured with OCT angiography. But the problem with this newer methods of OCT angiography is it's beautiful at showing capillary dropout, shown in the inferior retina here in the same location where axons have been damaged from glaucoma, for example. So here the damage is in the optic nerve head, the axons degenerate, and whenever you have loss of axons, you have loss of capillary perfusion, shown here. But it doesn't really give the dynamics of the circulation. It shows you really which areas are perfused or non-perfused, but it doesn't show you how much non-perfusion there is. But it beautifully renders all the capillaries and arterioles and venules. But again, it doesn't give the dynamics. And the reason we want to know about the dynamics is that we want to know what type of reductions in blood flow affect neuronal function. How much reduction in blood flow does it take before neurons start to be compromised in how they react and how they function? And also because we know that sustained reductions in blood flow will cause permanent damage, whether it's stroke in watershed areas in the spinal cord and brain or in the retina and the optic nerve. And conversely, we want to know how changes in neuronal function affect blood flow. So whenever you change neuronal function, you affect blood flow. That's the basis of functional MRI imaging, which we use nowadays in humans and animal models. But we can also study this in the retina. When you stimulate the retina by a flickering light, you also increase blood flow if there's neurovascular coupling. So neurovascular coupling is the mechanism by which the system delivers enough oxygen to meet the metabolic demands of the tissue. So if the tissue becomes more metabolically active, you need more oxygen to sustain it and more blood flow. If it becomes less active, if the neurons are dying, you need less blood flow. So this is all wrapped up in a neurovascular coupling, which can be very affected by diseases such as diabetes, for example. This is an image from the laser speckle flowography. We take a 4-second video, so about 4 heartbeats worth, so you can see the blood flow that's recorded during systole and during diastole. And then after the video is recorded, you can lay down areas of interest they call rubber bands in certain areas over certain arterioles or venules or over the optic nerve, and actually quantify these changes during the cardiac cycle in these different locations in the retina. And this is done with a modified retinal camera that uses near-infrared light around 830 nanometers, so there's no flashes of light. The patient isn't overwhelmed with any bright light because it's in the near infrared range. It's very easy to perform, 4 seconds per eye. It doesn't require pupil dilation. And you can do this in the human retina or an animal retina. And you can also use instruments very similar to this over the brain in mice or even in humans in the spinal cord during surgery. I'll show you some examples of that and why it's relevant to what you might be working on. It's based, again, on the principle of movement of red blood cells. The laser produces a speckling pattern, shown here, that's imaged in the plane of where you're looking at the blood flow. And so any moving particles, like red blood cells, that move across the speckling pattern will blur the pattern that's directly proportional to how fast the red blood cells are moving. And so this blurring, or the blur factor, is directly proportional to the blood flow, and that's how it quantifies blood flow dynamically. In each pixel, we have a measurement of blood flow. So again, here's a typical picture, and then we look at the different locations of interest after the fact, so you don't have to define them beforehand. After you have the video, then you can look at specific areas of interest and quantify them. Here's, for example, a similar instrument that we use in the mouse brain. Since it's near infrared, it penetrates through the skull. And this is, we have an NIH grant to study radiation changes, what happens after radiation. There's neuronal loss eventually, and many people, including us, have evidence that this is due to effects on endothelial cells, mitochondria, and vasculature, and affects perfusion. And so here we're looking at changes in the perfusion before radiation, and during focal radiation, you can see there's a loss of blood flow. So blue is lower blood flow and red is higher blood flow in the area of radiation. So you can use this tool to study the dynamics of blood flow in humans and in animal models of disease. Here is an application of laser speckle blood flow and light reflectometry at the same time. So some of these instruments not only measure blood flow, shown here, but in the same instrument measures reflections of light in the wavelength around hemoglobin. So that, for example, using this instrument in a mouse brain, you can induce cerebral hypoxia, shown here. The blood flow goes down, and you can see the oxyhemoglobin goes down at the same time that deoxyhemoglobin goes up. So you can sample this on a pixel-by-pixel basis in real time, which is very advantageous if you want to see the effects of ischemia on blood flow, oxygen, and other factors. Here's an interesting article that was done with human spinal cord laser speckle blood flow as it changes with mean arterial blood pressure. So this is a person that had a normal spinal cord but was undergoing spinal cord surgery, not because of trauma, because of, for example, a tumor. And what they're showing here is that when the mean arterial blood pressure changed within the range of 85 to 100, the blood flow in the spinal cord stayed constant because of autoregulation. But as soon as the blood flow dropped below this level, down between 70 and 80, the blood flow dropped proportional to the mean arterial pressure. So in areas where there was a decreased mean arterial pressure, the blood flow is going down in the spinal cord. So they were able to determine, once the blood pressure in that human started dropping below the autoregulatory range, watch out, because the areas of the cord can become ischemic. And then the similar paper studied during surgery after an acute cord trauma. And what was interesting is they also studied areas of blood flow in the spinal cord. You can see this is a very ischemic area right here. And what they were trying to do is to see if blood pressure could be increased, whether the areas of ischemia could become reduced. And in many patients, it did help blood flow tremendously. But in some cases where they injected norepinephrine to increase blood flow, it was at the expense of perfusion. So some areas actually reduce perfusion because norepinephrine not only increases blood pressure, but it does so by vasoconstricting some blood vessels. So these agents that anesthesiologists commonly use to increase blood pressure during surgery may not be such a good idea, because I've been involved in a number of lawsuits where a person wakes up blind after using adrenergic agents to increase blood pressure during surgery, because it affects the blood vessels supplying the optic nerve as well. So I'm just giving you a sample of kind of how you might be able to apply these methods in some of your research that has to do with spinal cord injury and blood flow, as well as brain models. Back to the eye again. This is a diabetic veteran who lost vision every time he went out in bright light in the right eye. And why did that happen? Well, when you looked at his blood flow in his eye, you could see that the right eye, shown on the left-hand side here, and compared to the left eye, the blood flow was much different and dropped much lower, especially during diastole. And he was investigated and found to have carotid artery stenosis on this side. You can see with ultrasound, he was only perfusing the brain and the eye mainly during systole. The perfusion pressure dropped dramatically during diastole because of the stenosis that occurred in the carotid artery, whereas on the left side, it was fairly normal. And then after a stenting procedure, next day, blood flow came back to normal and he didn't have the amaurotic episodes. Because of neurovascular coupling, when he went out in bright light, he was stimulating the retinal neurons, but he didn't have enough blood flow to keep up with the metabolic stimulation. And so that's why he's going blind every time he went out in bright light. So it's very interesting how we can look at this in the eye without having to do any other imaging. Here's a collaborative study we did with our neurointerventionalists looking at stenting of the carotid, and you can see the before picture. Again, this patient had a lot of decrease in blood flow, especially during diastole, and then post-stenting, everything comes back towards normal again. So we're now using these blood flow changes in the retina as another indication whether someone should be stented or not, because you can imagine something very similar is happening at the brain side as what's happening in the retina and the optic nerve. Here's a glaucoma patient. Glaucoma is a progressive optic neuropathy that has something to do with eye pressure. When eye pressure goes up, it makes it worse. But also many patients have what's called normal tension glaucoma. They have glaucoma, but their eye pressure never went up. And it's an enigma what's causing the problem. But what you can see in this patient, who was such a patient, is that when we did laser speckle fluorography, let me show you what that looks like with time. Get the pointer here. There was much decreased blood flow because he didn't have any carotid artery disease, but he had downstream high resistance in the small vessels, which was causing reduction in blood flow. And the reason that these blood flow problems are of interest is that new ways of increasing blood flow are being developed right now. For example, for the eye, a company has made an implantable drug that inhibits endothelin receptors that lasts for 6 months, which increases blood flow about 35 to 40% in the eye. And similar things could be implanted, for example, in the spinal cord during surgery to vasodilate and increase blood flow. So there are ways of changing blood flow coming up in the future that this has relevance to. And also some of the stenting procedures now can go much more distal than just the carotid artery, can go into very small distal vessels that may only be 200 to 300 microns in diameter and expand them to increase blood flow. This is a patient with retinitis pigmentosa, which is a degenerative disease of the photoreceptors they lose rods and cones, and they lose their peripheral vision, shown in this visual field test. And the reason I show this is they have very poor blood flow. And in this case, it's because, remember when I said when you lose neuronal function, you also decrease blood flow. So you can decrease neuronal function by decreasing blood flow, but on the other side, once you start losing neurons, you don't have as much metabolic demand and you don't need as much blood flow. It's a sign of neuronal loss. We recently received a grant from the VA. This is a Career Development Award. We found in patients that had aging macular degeneration, the dry type, not the type that has neovascularization that's receiving injections. Some of you might have relatives or know people that have macular degeneration. And what we found recently is these patients have extensive areas of low blood flow in the retina that far exceeds the area of retinal degeneration. And so this is showing kind of a frequency distribution of blood flow in the normal retina here. And this is the group of 25 patients we tested with macular degeneration. The healthy one is dashed, and the macular degeneration patients are here. So everything is shifted way over to the left, where blood flow is greatly reduced. And we saw this both compared to age-matched controls, both in very early stages and intermediate and advanced stages. So we think that blood flow may be an inciting factor in macular degeneration, and that's why we're very interested in monitoring it and whether some of these interventions to increase blood flow may be a new way of treating this very prevalent form of macular degeneration in veterans and in non-veterans. Another very important blinding eye disease that we see is giant cell arteritis, which is an inflammatory disease of small and medium blood vessels, arterioles of the human in different end organs. If it affects the brain, they might get a stroke. If it affects the eye, they get an infarct of the optic nerve head. If it affects the heart, they could get an MI. If it affects the intestinal arteries, they get an acute abdomen and end up in the emergency room because of ischemia to the bowel. But in this disorder, there's actually a thrombus or an occlusion of one or more of the posterior ciliary arteries. So here's a fluorescein angiogram, and that whole area is not filling, and it's not perfusing in the same eye that we did this study in. And this is very important to diagnose early, because if you treat them with high-dose steroids to reduce the inflammation, you can often save vision. Otherwise, they go completely blind, and the other eye can go blind within a week as well. So here's 6 such patients. You can see how low the blood flow is acutely when we first see them. That's compared to a non-ischemic, non-arteritic ischemic optic neuropathy, which are shown, in these 6 patients. So this is a form of ischemic optic neuropathy that's not due to occlusion, but it's due to hypoperfusion. These patients wake up from sleep with vision loss because most of us drop our blood pressure during sleep, but some of us drop it a lot more than others. So some of these patients during sleep drop their blood pressure tremendously. And so areas that are in what are called watershed zones are very susceptible to ischemia. Now in the eye, these watershed zones, shown kind of in blue here of low blood flow, are also seen if you inject fluorescent dye. You see these bands or these areas, they're slow to flow. They're slow to fill, but they do fill within a few seconds. But everybody has watershed zones. But these are areas, if you drop blood pressure significantly, these are areas that are susceptible to ischemia. So think of it as a garden that's being watered by multiple sprinkler heads. And if you drop the water pressure, the area in between the circulations is the watershed areas that don't get perfused normally if you drop the water pressure, in this case the blood pressure, too low. And so these watershed zones occur in different locations depending on how you were born with your circulatory anatomy. They're not all in the same location. And this is a significant risk factor for low blood pressure. And there are similar watershed areas in the brain I'm showing on the left. So between major circulatory distributions in the brain, these are the areas in between them. And these are typical watershed zones that are seen in this type of a stroke from a watershed infarct. So these are patients that have dropped their blood pressure too low during surgery, or they had a major hemorrhage or bleed, and they end up with a stroke in watershed zones. And the same thing is present actually in the brainstem too. There are watershed areas in the brainstem that are susceptible to low blood pressure, and also in the spinal cord. The areas in green are the areas between the different circulations supplying the spinal cord. So these areas are very susceptible to ischemia and to low blood flow and to low blood pressure. Back to the eye again, if you measure blood pressure with a 24 ambulatory blood pressure cuff that you just can put on the patient and measure the blood pressure every 15 to 20 minutes during waking hours and during sleep, you get an idea that these patients, some of them drop their blood pressure too low during sleep, down into the 40s, even in diastolic. And these are the patients that have been shown to have a high risk of optic nerve damage. And so we're very interested in determining who those patients are, whether the watershed zone, as shown here, includes the optic nerve head, and whether those patients can be treated before they lose vision. So it's a very important area of research that also spills in, again, spinal cord and brain has the same issues. In some of the, for example, the vascular dementias, which are similar in a way, may be due to too many drops in blood pressure that could be occurring during sleep or during overtreatment of high blood pressure, for example. Here's some of the work that we're doing in this regard. You know, there are some companies make telemetric sleep monitors that measure not only if you're having sleep apnea and stop breathing during sleep, but also the probe goes on the finger, and this finger probe measures the peripheral perfusion in the digital arteries supplying the finger. And whenever, for example, there's vasoconstriction, what happens is this peripheral artery tonometry, that's a device just like a cuff over the finger you wear continuously, the pulsation goes way down and is quantified wirelessly with this system. And the reason I bring this up, this is a recording during a patient during sleep. And here's during snoring, and here's during an apneic episode. And what happens is, often this happens during REM sleep. And what happens is this peripheral tone goes way down because of sympathetic nerve stimulation. So whenever you either have excessive REM sleep or you have apnea, the sympathetic nervous system is stimulated and you get vasoconstriction. And so we're very interested in this as a risk factor for why some people have decreased perfusion to the spinal cord and brain of the eye during sleep. And it's important because the sympathetic nervous system may innervate the heart, so the heart rate may go up, for example, with sympathetic stimulation, which you think could be good, but it may also excessively stimulate peripheral nerves that go to the cardiovascular system, and it may raise the blood pressure, but at the expense of end organ perfusion. So you're constricting down the blood vessels, which raises the blood pressure upstream, so you monitor with a cuff and the blood pressure goes up, but downstream in the end organ, you're getting ischemia. And so we're very interested in looking at how the sympathetic nerve stimulation with different maneuvers affects the ocular circulation. So, for example, here's a lower body vacuum chamber that patients were put in, and it puts a vacuum on your lower body from your waist down, and that pulls blood into your veins in your legs. And that lowers the blood pressure very mildly, enough that it stimulates the baroreceptors in your large vena cava, and that doesn't change blood pressure, but it increases sympathetic nerve activity. And my colleagues and I recorded from the sympathetic nerves in the perineal nerve in the leg during this maneuver. And we also recorded blood flow in the eye. And what we found is that the greater action potentials that we were able to stimulate with this lower body suction, you can see on the x-axis here, as the sympathetic nerve activity went up, vascular resistance went up in the eye. So as is a direct link between when you stimulate the sympathetic nerves, vascular resistance goes up. You can imagine that very susceptible end organs like the spinal cord and the brain and the eye are susceptible to this sympathetic nerve overstimulation, which would be a bad thing, cause decreased blood flow. We also did a sympathetic nerve stimulation using a cold pressor test. I'm going to rename that the Cleveland December test now. And you immerse their foot or their hand in ice water for 2 minutes. And using this same finger probe, you can measure peripheral vasoconstriction from sympathetic stimulation. And when we did this, you can see that this amplitude goes way down with cold water immersion because of sympathetic nerve stimulation. And we recorded in the eye the same thing. And essentially what's happening overall in most of the subjects, there's an increase in vascular resistance. So when you go out in cold, some of you are susceptible and you see your fingernails turn blue because you're getting peripheral vasoconstriction from sympathetic nerve stimulation. Well, it also could be happening in vital organs, so too much is not good either. So we're interested in whether we can modulate this or at least protect some end organs from overstimulation of sympathetic nerves. We also use hemodialysis as a model. These patients that are in chronic renal failure, they're getting dialyzed 3 times a week. They take out a couple liters, fluid from your blood. So you get volume depleted during dialysis. And we are interested in what happens to sympathetic nerve stimulation and the blood flow in the eye during this time. And the reason that's important, not just to the eye, is that some people lose vision over time with dialysis, but some people also, have been a number of studies, lose cognitive function over the years. And the question is, what's happening to the brain circulation as a result of this volume depletion during dialysis? And if you talk to patients while they're getting dialyzed, they get very tired during the dialysis. They're sitting there and their mental function declines. And you got to wonder, these large swings in plasma volume that are happening, what's that doing to the peripheral blood flow? So we recorded ocular perfusion pressure, which is just the blood pressure taking into consideration the eye pressure at the same time. That goes down some during dialysis. 3 time points shown here: start, middle of dialysis, and end of dialysis. But the retinal and optic nerve blood flow goes down significantly. And it's more than can be accounted for than just the drop in blood pressure. So we think sympathetic nerve stimulation is happening besides the blood pressure going down, which is causing vasoconstriction, which is not necessarily a good thing. And so this is the first study to really demonstrate that we have to be careful during dialysis not to over-dialyze and not to reduce blood pressure too much, or there may be significant sequelae. And so now we're studying function of the eye during dialysis with a portable electroretinogram. We're also interested in studying cerebral oximetry at the same time, and we're doing cognitive testing to see what happens to cognitive function objectively. So just to summarize, we're looking at ways of influencing the vasculature and monitoring it during sleep, during things that stimulate the circulation, sympathetic nerves that may cause vasoconstriction, and the role of provocative tests. I want to show you, just to end with a few provocative tests. This is a light flicker test. A person looks into this laser speckle camera, and we flicker the light, for let's say 15 seconds. And what happens is blood flow goes up significantly, almost 35 to 40%, because we're stimulating the retinal neurons. We're causing them to be more metabolically active. And a normal eye, blood flow goes up in all vascular beds of the eye, and vascular resistance goes down because of vasodilation. There's some patients that have a condition called CADASIL, which is an inherited condition. that is cerebral autosomal dominant arteriopathy with subcortical infarcts. And those have been shown to lack neurovascular coupling in the brain. And we tested one such patient with this method, and they had practically no change in blood flow with flicker. So there are diseases where this neurovascular coupling is impaired, and then that leads to stroke. So it's very important, like I said, especially in diabetics. We did the same light flicker test in a patient with glaucoma, shown here. And what I've done is the area of the optic nerve that was most affected by glaucoma, which is right here where this blue region of interest is circled, compared to the upper part of the optic nerve rim, shown here. I'm graphing what happened to blood flow with flicker. And you can see the area that was less affected by glaucoma has good increase in response to blood flow with a flicker, but the damaged area has a very poor response. And this is the visual field of the patient, where the upper visual field, which corresponds to the lower nerve bundle here because of the optics of the eye, is what's affected. So this is a provocative test that we're using in patients where they had damage in this area to see how the vasculature responds to a provocative test of flickering. The nice thing about this test is you can put these rubber bands over the optic nerve or over the retinal arterial supplying the damaged in the somewhat normal area to show the similar aspect, that the damaged area show a reduced provocative response to light stimulation in terms of their blood flow increase. This is a second type of test. There's a special eye goggles you can put on that produces a vacuum that lowers intraocular pressure acutely, which when you lower intraocular pressure, that raises perfusion pressure. So here's a way of increasing blood pressure to the eye, in a way, perfusion pressure. And when you record continuously in a normal person, you can see as soon as the eye pressure goes down, the blood flow goes up dramatically. And then within seconds, it comes back down due to autoregulation. So this is a way of stimulating and assessing autoregulation in the living human eye in different locations of vasculature, both in the retina, the optic nerve, and the choroid. And so when we do this in the normal eye, there's very little change in blood flow because of autoregulation when you increase perfusion pressure. And that's because the resistance goes up, because these vessels constrict to maintain blood flow at a constant level if you increase perfusion pressure. And if you do this in, again, a glaucoma eye, you see something entirely different. So these are eyes that need more blood flow. So right now the metabolic demand is not being met because they have reduced blood flow. And so in those cases, unlike normal eyes, they don't autoregulate. Their blood flow actually goes up with these vacuum goggles. And the company that makes these goggles is marketing them for a patient to wear during sleep. It's just a mild vacuum. It's just like going underwater, 6 or 7 feet, the pressure that you feel. And so the idea is to increase blood flow to the eye during sleep to avoid too much reduction of blood flow during sleep, which I commented on earlier. And getting back to using laser speckle and the spinal cord, so this is after spinal cord injury. And what they were doing here is showing that in the spinal cord injured patient, this is a normal, in a human that's had spinal cord injury, there are different areas. There's areas that are spared that have normal blood flow, shown in the red pixelated area, areas of intense ischemia, blue, and then this area in between, which is called the vascular penumbra. So that's the area that is kind of in between and is very susceptible to further damage. So the idea is that could you increase blood flow in those patients if you detected it during their surgery for their spinal cord injury, and do something to increase blood flow to improve outcome in the end. And so that's an intense area of research that might be applicable to some of what you're doing here. So just to summarize, I wanted to show that this technique of laser speckle flowography provides a dynamic and a quantitative way of assessing blood flow in different vascular beds simultaneously in the eye, but it also can be used in the brain and spinal cord, both in animal and human models, that is able to show us dynamic changes in blood flow, both from disease and treatment interventions. And so I think that's the idea, is that we want to be able to also show that if you improve blood flow, that you can improve function in those areas. And the last thing is that we might have available now stress tests of microvascular function that test neurovascular coupling by nerve stimulation using autonomic reflex stimulation that changes perfusion pressure or sympathetic nerve activation to give insight into how we can test these neurovascular systems to see whether they're deficient in certain disease states and whether there are ways of remediating that. So I think that's the final message that I wanted to give, and I wanted to thank you for coming out on a cold afternoon.
These watershed regions seem like, as an engineer, a really poor design. So, I mean, I don't. I just want you to comment on why they're there. I mean, why wouldn't there just be? Is it just the way it is, or?
I think every vascular development, has multiple ways of trying to supply enough blood and oxygen to the area, and it does a good job in the normal state. It's just, I think, those areas that are just at the in-between points, I don't think there's a way of, why doesn't the circulation develop in a better way that there aren't watershed zones? I don't know where the design problem was. It's also very nicely designed because it distributes oxygen in a very parsimonious way to very small areas of tissue. And it's surprising how small these areas are. So in other words, the neurovascular coupling part of it is very well designed because you don't distribute blood flow where it's not needed. It's always in proportion to metabolic demand. It's just when metabolic demand exceeds what's possible because of pathology, that's where we run into trouble.
You were talking about vasoconstriction during certain, like in the brain. Mm-hmm. Like that also seems like, what? That seems like, when I think of vasoconstriction, I think about my fingers getting blue, but not my heart and my brain and I thought that was to preserve those organs.
It
right?
does to a certain extent. For example, the extracranial vessels are heavily innervated by sympathetics and parasympathetics, but not so much the intracranial vessels. And same thing with the retinal arterioles. The retinal artery in its course through the orbit is heavily innervated, but as soon as it enters the eye, it loses all innervation. So there is some protective mechanism, but vasoconstriction of the large vessels that are innervated can reduce perfusion pressure, and if it exceeds autoregulation, then that's when you get these, watershed infarcts, for example.
I have one comment and one question. So the comment is, it's interesting that video that you showed where unilateral carotid stenosis and person going out in bright light and getting blind. Mm-hmm. So there is a very strong Cleveland connection with that sign. So my former chair, Tony Furlan, when he was a fellow at Mayo Clinic, he was rounding with one of his mentors, and they saw a patient like that, and then his mentor pulled out back in those days they used to have iron cabinets and the cards. So he pulled out the cabinets and pulled out like 5-6 cards saying like, here, same patients like this and this. Why don't you write it up? So they wrote up a case series like that, and they had speculated all the mechanisms. This is in the 60s, 70s. And ever since they've been calling it Furlan sign. So that sign is actually in our department known as Furlan sign.
Interesting.
It's kind of very interesting. So I took a video of you presenting and I sent it to Tony Furlan.
Apologize for him for me not naming it after him when I gave my talk.
A local
I don't know. Yeah, I mean, I don't know how popular it is, but I only did stroke in Cleveland, so I have no idea. And the second question I had is very interesting about autonomic dysregulation and the blood flow measures. It can be marker for several autonomic neuropathies. Likewise, did anybody look into diseases like multiple systems atrophy versus Parkinson, right? So one is more prone to have fluctuations in the blood pressure and dysregulation in the blood flow. And their pressures can drop pretty significantly low sometimes. So this test maybe can be used as a marker to separate one
because it
versus
probably
the
has
other.
affected the eye circulation as well as the brain circulation.
Yes.
Are those patients more susceptible to ischemic hypoperfusion strokes?
You know, I don't know if there is a literature on it, but if they do have vascular risk factors, then I don't see why not, because when they are sitting and then stand up, their fluctuation is significant, and sometimes they can't even syncopise. It's that bad. So, and if they have a focal narrowing in their brain, then clearly it can cause strokes, right? So,
And as we were discussing earlier today, that the autonomic system is one of the first systems to be affected in Parkinson's, right?
yeah, but this is, I mean, PD, Parkinson's disease itself has blood pressure fluctuations, and as they advance further. But MSA, multiple systems atrophy, which is atypical Parkinsonism, it's notoriously known for that.
I wonder if that's where some of the atrophy comes about from ischemia.
You know, it's a good thought. I don't know. I mean, it is synucleopathy, of course. So people think it's because of synucleopathy, and wherever there is more synuclein, that then leads to more atrophy. I mean, that's what most neuropathologists think. But for sure, there could be some vascular component to it.
Thank you.
Very interesting talk. I learned a lot. I'm wondering what your thoughts are using speckle imaging on periphery for applications like diabetic neuropathy, peripheral neuropathy, or even limb ischemia. Has it been tried before?
Yeah, there are some papers on that where they're using for blood flow in the foot and fingers, and doing provocative tests also, as well as thermography too, in terms of, another little bit further removed from blood flow, but similar to blood flow in a way, because it's going to affect, temperature on the periphery. But I think it would be definitely applicable to study peripheral autonomic neuropathy in those cases, because it's dynamic, and that what you'd like to have is some type of provocative test, maybe a cold water immersion test or something to show that it's, even worse with some provocative stimulus. So you have something in the same patient to look at with time.
So, I also learned a lot today, Randy, I have to say. So, my question has to do with the autoregulation. So how much of that is intrinsic to the vessels and how much of it is autonomic, let's just say?
Yeah, that's a really good question. That's where studying the retinal circulation is really helpful, because as I mentioned, once the retinal artery enters the eye, it loses all autonomic innervation. And so we're very interested in studying this whole phenomena inside of the retina at different retinal branches to see if autoregulation, separating out the intrinsic component, which is thought to be due to the smooth muscle sensors and parasites that control. What's really interesting is some of my colleagues, I didn't get a chance to say what this last slide is. This is one of my colleagues from Rochester, Jesse Shallak, and he uses a type of adaptive optics called split spectrum adaptive optics to measure, this is in mouse retinal capillaries, okay? And what he found, which they didn't teach us in medical school, is that So each one of those little things is a red blood cell. Is that we were taught that the arterioles, tone of the arterioles controls capillary blood flow. He showed that the capillaries themselves can change diameter with parasites and can change the density of red blood cells flowing through that capillary. So it's not just blood flow as we think about it, it's how many red blood cells per minute are flowing through a given capillary at a point in time. So that's meant that the regulation of this at the capillary level is much greater than we ever thought it was. That, I mean, showing the same capillary at two different time points, you know, how you get the rouleau formation when everything's flowing through, like, you know, 2 in the morning on the highway, and then what happens, you know, at what rush hour when, you know, the capillary is trying to control exactly at the expense, you know, where it needs oxygen, where nearby capillary needs more or less. So it's a very interesting phenomenon, the whole autoregulation. It's not just at the arterial level.
This is from Dr. Peachy. Is there a plan to follow the control non-AMD subjects with low choroidal perfusion?
Yes. So one of my mentees, Edward Linton, he just got a Career Development Award from the VA. And that's his project, is we're going to recruit a larger cohort of ones that don't have AMD and ones that do. And we're going to be studying them hopefully over a long period of time to say not only whether the ones that have very mild AMD, whether they're predictors of who's going to progress based on their blood flow, but as the question I think is trying to ask is, can we detect very early on in patients who don't have any clinical signs of macular degeneration that have low blood flow, whether they're going to eventually develop some form of macular degeneration. And like I said, the reason this is important is if it's a significant risk factor that can be modified by either implanting of a device that vasodilates, or, as I said, the stenting of very small vessels like the ophthalmic artery, which can increase blood flow and maybe remediate this. It's not just finding them earlier, it's really having a treatment that might be able to reverse the progression. So I think that's a very good, astute question.
Thank you.
Okay. Is that it? All right.
Okay, thank you again.
Thank you.
Appreciate it.